Hi, everyone. Good afternoon. Thank you all for joining us and thank you for your patience. Today, we will be hosting our webinar called The Future of Emergency Medicine, How Technology and Clinical Informatics Are Transforming Care. I'm John Dickens, and I'm excited to be hosting this important conversation about how emerging technologies, especially AI-assisted charting and predictive modeling, are reshaping emergency medicine. We've got an incredible panel lined up today. Two physician leaders who are actively working at the intersections of technology and emergency care. They'll be sharing their firsthand experience with implementing these tools, how they're improving clinical workflows, and what this means for the future of our specialty. Here's how today's session will flow. We'll start with some brief introductions, move into our panelist presentations, and then we'll open it up for Q&A. I'd kindly ask that you hold your questions until the Q&A segment so that we can keep things running smoothly. We've got a lot to cover, so let's get started. As I said, my name is John Dickens, and I'm a PGY3 at Northwestern University in downtown Chicago. Before residency, I worked as a project manager for companies like Epic and Humana, and my research and academic interests are primarily in the development and implementation of new technologies in the emergency department and in new models of care management. Our first panelist is Dr. Marta Rowe. Dr. Rowe is an assistant professor of emergency medicine at Emory University and a leading researcher on artificial intelligence applications in medical education and clinical practice. Her work focuses on leveraging AI to improve physician efficiency, optimize healthcare documentation, and address biases in medical curricula. Dr. Rowe will be presenting on AI-assisted chart generation and AI review of bias in patient charts and medical curricula. Our second panelist is Dr. Alex Finn. Dr. Finn is a clinical informatics fellow at UNC Health, where he also completed his emergency medicine residency. Dr. Finn will be discussing clinical informatics and predictive analytics in the emergency department. With that, I'll turn it over to you, Dr. Rowe.
Thank you so much. And as John mentioned, there's a ton to talk about here, but I want to make sure that we have enough time for discussion. So I have condensed this talk a little bit to make sure that we're able to take time for questions. At a couple of times during the presentation, I'll be asking for your participation. So while we requested that you hold questions until the end, please do feel free to come off mute, jump in, and talk during the presentation when prompted. So thank you so much for the introduction. My name is Marta Rowe. I'm an emergency physician first and foremost, and have been dragged into many other areas of our specialty, sometimes kicking and screaming when things change. So one of the biggest changes that we've had in our field is the use of AI-assisted everything, both education, charting, differential diagnosis and development. So many things are now touched by AI. So I will be talking specifically about AI-assisted charting, what that means for learners, and what that means as an emergency physician managing several patients. So let's get started. All right, where is the technology right now? So at this point, there are a variety of technologies that can be used for generating charts. I've got everybody's picture right in front of my slides. That's all right, I know it pretty well. So the goal of these technologies are to improve physician efficiency and billing. So one of the things that you'll be held accountable for as you move into your attending physicians is how many patients per hour you're seeing, what sort of billing you're able to capture on your charts, in addition to all the great care that we expect you to provide our patients. So we've completed several studies about physician charting. First thing is that physicians generally say they hate charting and that it's one of the least rewarding portions of their job. Some of you may remember, if you've been doing this long enough, that we used to have actual humans as scribes following us around with those things that we could no longer call cows and writing down everything we said. So right now, we now have AI-assisted technologies that can do that for us. So you turn the application on as you enter the patient's room, and it will listen into the entire conversation. It'll generate a history, a physical, and an assessment and plan. The goal of these, as we talked about, is to improve that billing accuracy and the physician efficiency. Right now, everything that goes into that chart has to be spoken out loud. So my assessment and plan would include follow-up with orthopedics. If I say to the patient out loud, I would like you to follow up with orthopedics. In the future, this is not simply going to be a transcription technology, but rather more like what we consider AI. So it'll integrate historical medical records, it'll integrate current best practices. It'll be able to look at things like up to date for you while you're standing there and talking to the patient. It'll generate that differential diagnosis and it'll put together a treatment plan. Still, it's important to remember that this still is going to be focused on billing and efficiency, and the aid will really be focused on moving those two metrics forward. So as we've done this research and we've sort of asked these technologies to make us more efficient, make us faster, make us better at billing, we need to stop and try to understand what that changes about the doctor-patient relationship. And the best way to ask that question is by a case, of course. So you've all spent a lot of time with cases. So we're going to look at case one. This is a 52-year-old male. He's coming into the emergency department 2 days after an MVC. He still has some pain in his right arm and on his right side. His shoulder's a little achy. But because of these sort of low acuity complaints, he's been in the ED in the waiting room for quite some time. He saw a triage nurse that ordered a right elbow x-ray. No labs were ordered. Before you even go see the patient, that x-ray has already been resulted and shows no fracture. You look at his charts, that his vital signs are within normal limits. You go in to talk to him and examine him. So he's got normal range of motion of his wrists and his shoulder. He's got a little bit of limited range of motion due to pain on his right elbow. He's reporting some swelling that you're not really able to appreciate on physical exam. He has some general chest wall tenderness. You don't see any bruising. The patient really wants you to give an arm sling and pain management options. Okay? Even before you left the room, that AI technology has already created an assessment and plan, already written your chart, already put together your discharge medications. All you have to do at this point is hit ready to go. All right? Your AI assisted technology gives an assessment and plan. 52-year-old male, 2 days after an MVC with right-sided upper extremity pain and diffuse right-sided myalgias. Gives you a huge differential diagnosis to try to increase the amount of complexity of your chart. Recommends RICE for that right elbow, NSAID for pain management, a short course of opioid narcotics because that increases the risk of your chart as well. They also throw in some naloxone there because we want to make sure that the patient has an understanding of the risk of these medications. And then follow up with orthopedics if that pain is unimproved. Anybody have concerns about that assessment and plan? Does that seem pretty reasonable? It seems pretty reasonable to me. So what else could be going on for this patient? So we're going to look at 3 sort of sub-scenarios. It's the exact same patient. But for this first scenario, I call this case 1A. This gentleman originally had a knee replacement about a year ago, received 60 Percocet at the time. Prior to his knee replacement, he was an avid golfer, played doubles tennis with his wife. After his surgery, he still hasn't really been able to manage the torque associated with his golf swing and has lost some buddies and some consistent socialization that he used to enjoy. His wife, who he used to play doubles with, has noted that he's still a little bit slower, basically hasn't been able to participate as much. She actually just recently got a different doubles partner and has continued to socialize that way. He's been back to the orthopod several times for pain. He's received several refills of that narcotic medication, but at this point, his orthopedics team is planning to taper his narcotic pain management and send him for more aggressive physical therapy. He's marginally invested in this plan, but really feels like he's being abandoned by his surgical team because he hasn't improved as fast as they wanted him to. All right. Our second scenario. So this is case 1B. This gentleman was recently laid off from his government employment. He is still undergoing a divorce that's been lasting about 8 months. He was married for 28 years and the process of the divorce has just been ongoing. He's had some insomnia at baseline, but believes this arm pain associated with the recent MVC is worsening his insomnia. He feels overwhelmed and after the accident just really doesn't feel like he can go out into the world, specifically anything that involves driving. He's done some internet searching and actually feels like this may be due to a concussion, although he can't specifically remember hitting his head during the accident, and there's no head trauma that you note. But because he's unable to concentrate, he really believes there's something terribly wrong. He's struggled with his ADLs ever since the accident happened. And then this is the last one. So this is the third case. And for this one, I'm going to give you a little bit of a window into the future. So for this gentleman, he continued to have swelling to that posterior elbow. His range of motion continued to worsen. And what really prompted his follow-up, he was unable to hold the dog leash with his right hand. So when he usually walks his dog, he's really had so much pain in his elbow that he wasn't able to do it. So he did make that follow-up orthopedic appointment that you recommended if his pain was ongoing. He was found to have an occult radial head fracture and a tear of the triceps tendon on MRI. They've put him through a series of rest, immobilization, and then physical therapy in order to treat that. So in considering these more detailed scenarios, which of these patients would actually benefit from narcotic pain management? So clearly, narcotic pain management is one of the more risky things that we do. There are a lot of ethics involved in it, both who we do and don't give narcotic pain medication to. And what we are tasked with assessing the risk, even though all of the studies at this point show that we do it very poorly, of someone's use or risk of developing an opioid use disorder. All right, so let's go back to this AI-assisted technology. So let's say you didn't feel like narcotic pain management was really in the best interest of our first two patients. How likely would you be to rewrite that AI-assisted assessment? How likely would you be to completely change the plan and spend extra time sitting with that patient to discuss why you are not going to be giving that narcotic pain medication? And I want to make sure that we remember the context, and I left this picture here to discuss or to remind that we are in the middle of a busy emergency shift, and you know that you are being charted on or being clocked on your efficiency and your billing. And you know that both of those would take a hit if you decide to rewrite this. So I hope this has demonstrated how something as relatively benign as an AI-assisted charting application can really change how we interact with our patients. If you know that if you have a simple discussion with that patient, that your note, your assessment and plan and everything is completely taken care of for you as soon as you step out of that room, you may approach the interaction differently than if you know that you're responsible for creating that entire chart. And you can start from the very beginning by describing the first two scenarios that we discussed as involving either increased risk for opioid use disorder or a psychosomatic component of the pain that you believe the patient is having. These are the kind of assessments that AI is terrible at making. And honestly, there's no goal for teaching AI how to do that. These are assisted technologies that are focused on efficiency and billing, and we should treat them as such. It's going to be important, particularly if you are coming of age during a time when we use these, to understand what sort of challenges these type of assisting technologies pose for that doctor-patient relationship. And with that, I will stop.
Thanks so much. Really interesting topic, very thought-provoking, a lot of ideas, and I'm sure we'll have some questions in the Q&A about the applications of technology and AI with chart generation. Thanks so much, Dr. Rowe. Dr. Fenn, are you ready to present your presentation?
I am indeed. So thank you, John. Dr. Rowe, that was fantastic. So John kind of came to me and I was kind of given free rein as to discuss like what it is that interests me as a clinical informatics fellow. And so I decided to just kind of initially talk about a project that I was actually involved with as a med student, which I think for, especially for those in SAEM and trainees, that just kind of example of a way in which you can be involved and then thinking about just the future, which I think dovetails nicely with Dr. Rowe's talk. So wanted to talk about a project I worked on, not when I was at UNC, I was down the road at Duke. So don't tell them that I've got the UNC and Duke here, both presented on the slide. And so I worked on a project with this called DHI, which is the Duke Institute for Health Innovation. Essentially, they're an incubator for trying to develop predictive modeling to predict admission from the ED to either like an inpatient unit versus an intensive care unit. And so this kind of stemmed out of we know we're all emergency medicine physicians or trainees or EM related, and we know that the ED, like boarding in the emergency department, is indeed a problem. And then the demand for the inpatient beds often outstrips the supply, which is pretty difficult. And so we kind of took this and said, well, maybe we would be able to predict admission demand just when patients arrive right at the emergency department. And so the interesting thing about this is that this was developed kind of before the AI boom. This was like, I was working on this in 2020. And so this would be before kind of generative AI, but machine learning was still a thing. And so the goal was being able to create a model that essentially would update throughout the patient's stay and then also develop a framework just surrounding the model implementation and usage. And so we figured that with me on the right there as a ED doctor or a future ED physician creating this machine learning model, that on the left there you would then get some healthcare admin who are sitting and are very happy about the well-functioning emergency department. And so when you plug all of these, and I didn't want to get too technical, and I also didn't want to talk for too long, but when you plug all of these features, and so essentially what you do is you take this data set and you take all of these patients that have been seen in the emergency department over the last few years, and you plug it into a machine learning model, and you can essentially say, hey, what are the features of this cohort that are the most important? Like what actually predicts is the highest prediction for admission and in this patient cohort. And so what you can see is things that actually I would say that like these are things that we are looking at pretty significantly as an emergency medicine physician. And so thinking about the patient age actually ends up being the most important factor. And so I think this was the old adage in the emergency department. I heard somebody quip that the person's likelihood of getting admitted in a percent is just their age. So if they're 78, they have a 78% chance of getting admitted. You know, you're getting up to the 90s, pretty high chance you're getting admitted. So I think that kind of was confirmed in our model. And then a lot of other things like looking at patients' white blood cell counts and hematocrit, and then some of these prior length of stay visits and if they'd previously been seen in the emergency department and how long they've been hospitalized, just thinking about patient comorbidity. And so that is just a quick example of just how these models work and that they essentially assign features to different levels of importance. So what we did is we took the model and then we set different thresholds. And so we looked at, and this is the model is essentially then being output into a Tableau dashboard and then being able to look and say, okay, patients are here, here's their bed, here's their length of stay, and then also this is their likelihood of admission to either the intermediate step down floors or in ICU. And so the colors there were these kind of thresholds that we played with to say, hey, we think this is very high, medium, or low. And thinking about too, like with all of these, and you guys are probably aware of like the Epic sepsis model and that kind of constantly dinging and saying, hey, you need to consider this. There's a trade-off between the sensitivity and the specificity, and essentially like how much do you want to alert people, or do you just want to create a model that is going to predict that everyone gets admitted? And so a little bit of kind of getting down almost more into the art of medicine and the art of some of these models versus the science, and thinking about how much we actually want to pester physicians. And so you say, okay, so what? So I actually worked on this and then COVID happened. And so it's hard to believe that this is 5 years ago now, but the obviously all these sorts of resources and COVID just kind of like entirely changed the healthcare landscape. And so I was able to get this model out there and published. And from my understanding, from my friends that are still at Duke, is that it's still kind of there in the background, I think just potentially waiting for somebody to kind of pick it up and maybe run with it again. But the cool thing is that a couple years after we created this, there was this paper in emergency medicine that validated a model that is built into Epic. And so I don't know if any of you have this sort of model within Epic, but our model was kind of used as a initial framework and kind of talked about as, hey, this is a we looked at this and we thought that we could implement this into Epic. I don't have that at my institution, and so I can't say how accurate it is, but it was essentially when you looked at things like the area under the receiver operating curve and all those fun machine learning statistics, it was pretty accurate and precise. And so I think to me, this is just a example of what you can do in clinical informatics and things that as a trainee that you can reach out to stakeholders and physicians and data scientists at your institution and get involved in those sorts of projects. And I think also too, just an example of even kind of before the whole generative AI and everything along those lines is that machine learning models have existed for a pretty long time. And I think that we're just now thinking about how to integrate these into medicine. So I kind of wanted to end my talk, and I think this kind of will go well with just a question and answer session of just what next and what does the future hold. And so I went back, and when I was doing this, is something that I enjoy in all of my lectures is I like looking at history. And so I have actually now started at the EM residency I went to. I think pretty much all resident lectures now include like a little tidbit of history. And there's just some like fascinating medical history out there. And just like the more that you dig, the more you find that we probably people didn't used to know what they were doing. We probably still don't know what we are doing. But I went back and I looked at JAMIA, which is the Journal for the American Medical Informatics Association. For those who aren't familiar, I would say AMIA is probably the foremost society that is essentially medical informatics. And so there's a lot of physicians, they help run a lot of the informatics programs. And then there's also a lot of PhD faculty, people that are in private industry. And so I would say that if you're doing some kind of like really important work within medical informatics, like this is a really important journal. And so what I thought was fascinating, so I actually went back and I looked, and this was made helpful because there was an article just last month where people had been kind of talking about a retrospective of JAMIA. And so this is the first JAMIA issue back in May of 1994. So I had been born, but don't have a lot of memories. And you can see that in 1994, so now over 30 years ago, there were 9 papers on this very first journal, and they were talking about natural language processing, machine learning, expert systems, CDS, diagnostic reasoning, concept modeling, neural networks. And just for a little bit of reference, in 1994 was when Pulp Fiction was, in May of 94, as Pulp Fiction was released, and it was when Nelson Mandela won a post-apartheid election. And so obviously, like the world has changed a lot since then, but I was reading this and my mind was kind of blown because I was thinking like you could put those 9 AI papers in the May 2024 article of Jamia and people wouldn't bat an eye. And so I am curious as to obviously we have made so many, like you look at AI and you're just like, wow, this is amazing. But I also think that are we going to be talking about a lot of the same fundamental underlying concepts in another 30 years? And I think the answer is I don't really know. But I thought I just kind of wanted to highlight that we've been talking about these things for a long time and we're going to continue to be talking about natural language processing for a very long time. So this is another fundamental thing that we learn in clinical informatics. And so this is from Friedman, and this is in kind of establishing the idea of biomedical informatics or clinical informatics. The idea was that a human plus a computer is greater than just a human on its own. And I think that this, for me, as somebody who is undergoing informatics training, like this is really kind of the ethos of what we do, is thinking about how can I use technology? How can I use AI scribes? How can I use an auto-generated differential diagnosis in order to augment and make myself better? And so that to me right now has kind of been still at the core of what we do. However, I am curious as to at what point, if ever, we will potentially remove the human. And so in that previous slide, I think that's how we think about informatics. That's certainly how I still think about it. But I don't know how familiar you all are with the concept of AI agents. And so an agent, just in general, is essentially think of it like an AI assistant that doesn't even need you to interact. And so, like, you can say, there are now like AI agents that could book travel for you. So you could just give it its credit card and say, "Hey, I want to go to Hawaii and don't spend more than $1,500 and it'll take your credit card and it'll kind of run with it and do all of that." And that is something that is happening in 2025 and is only going to expand. And so part of me kind of wonders, is that human in the loop going to be taken away at any point? And I don't really know the answer to. And this is just kind of why I thought it was fun to just kind of think about what's next, because thinking about, okay, we've talked a lot about these same exact concepts over 30 years, but now are we finally on the precipice of something where we would be able to just remove the human and have AI agents be able to take care of a lot of things? I do know I was recently at an Epic talk. It was like the local North Carolina Epic user group meeting, and they have been doing they're really pushing generative AI, I think, just like any other tech company. And they are working on that in terms of things like auto scheduling and in terms of in basket. So I think in some of the low hanging fruit, we're kind of seeing that. And part of me just wonders, are we going to get to the point where it's just computer greater than human? And I don't really know the answer to. I think certainly for those of you that are on this call and are interested in informatics, you are inevitably future-proofing your career and certainly providing, I think it's very valuable to be somebody who's able to interface between the world of medicine and technology. So that is all that I have. I will stop sharing my screen, and it sounds like we've got questions.
Yeah, thank you so much, Dr. Finn. Definitely thought-provoking as well, and really makes you question from a moral, ethical standpoint, how important is that component and human connection within medicine, and where does AI and other technology fit in that? So I do have some questions prepared for our panelists, but I would love if our other guests as the audience, if you have any questions, please ask them now. Okay. Well, if others want to continue to think of questions to ask, I can start off with maybe one, and this is to both you, Dr. Rowe, and you, Dr. Finn. How do you, when you think about new technologies being implemented in the emergency department, and specifically with technologies dealing with either predictive analytics or AI assisted chart generation, how do you think about the balance between being efficient and thorough with an over reliance on technology? And what sort of considerations do you think our individuals who are working in emergency medicine are either planning on developing or implementing those types of technologies?
So I think that there's this delicate balance that exists, right? Because I think that, and this is not just AI in medicine, this is AI in general, is I think there's kind of these two camps of, do you want to be kind of like more of an accelerationist and go really far and like lean really hard on AI? Or are you really concerned and you want to say, hey, pump the brakes? And I think every individual and every entity kind of has their own balance that they find. I know, so for example, at UNC, this is entity-wide. Prior to implementing any AI, there are multiple work groups that are evaluating these sorts of technologies. And so I'm actually part of a work group called the Responsible AI Work Group. And vendors come to us all the time and say, hey, like, we really want to implement this. X, Y, and Z. And our job is to kind of go through and we have a set framework of saying, hey, like, how is this model developed? What kind of what kind of bias exists? And a lot of times people aren't able to give even super thorough answers, but at least just like making sure that any technology that we're implementing is vetted, and at least this is on an institutional level. And so I think that provides a really good safeguard, at least initially, knowing that if I'm using a product at the institutional level, then it's been pretty thoroughly vetted by a lot of people.
Yeah, I would say I would have two comments for that question. I think if you step back, there has been sort of a stretching of the doctor-patient relationship over at least the 20 or 30 years that I've been in medicine so far. So, we used to conceive of the doctor-patient relationship as this thing where we're both sitting in a room and then like I'm scratching some chicken scratch on a piece of paper that no one is ever going to leave. It's going to be like put in some, file somewhere. And so really most of my work was sitting across from another human being. And for a variety of reasons, that has become much less of what my work is, whether it's we're talking about observation medicine and using telemedicine, where I'm sort of a discombobulated screen and I don't actually interact with the patient, or whether I'm overseeing APPs or what we used to call physician extenders. And the idea being that these are my patients, but they're kind of not my patients anymore. And so we've taken that doctor-patient relationship and we've sort of made it very fuzzy on the outside, at least compared to what used to be. And maybe this is more familiar to folks who are training more recently, because this has sort of been the standard of care the whole time. And so I think as those different things have come into medicine, we tolerate much more this assisted technology in between us and the patient. And I think, again, Dr. Finn took a moment to talk about history, and I think the same thing applies here. If we think about how we used to do it and now what sort of space is being created between us and the patient, we may be less tolerant of some of these assisted technologies that are further separating us from the patient. And I think as the ethical considerations that task forces are meant to look at, there's a lot of ways in medicine where you can be not technically wrong, but miss some of the art of medicine. And I think those are the areas that we're going to lose the most. I also think on the other side of it, when we talk about predictive modeling, we really have to understand population risk and individual risk. And I love that you brought up the admission prediction model. I did a bunch of work with that associated with geriatric trauma. And yes, age is the one thing that will predict you are not going to do well. And as I get older, I'm more and more convinced that's not true, even though I play with those numbers all the time. But there's an individual patient in front of you. And we've all seen the 40-year-old that looks like they're 90 and the 90-year-old that looks like they're 40, maybe 50, whatever. You get the point. And I think there's a part of us that are then taught to ignore that individual difference that we're seeing in those patients. And the trauma service folks that I work with are actually very good, maybe because they're trained as surgeons, and saying, no, my brain is better than the computer. And sometimes I do it too much. But I think as an emergency physician, sometimes we're too lenient. We're too ready to say, maybe I don't know what I'm talking about. Maybe the computer knows better than me. So I love that algorithm or the theorem that you put up there, because you really have to understand where your brain fits into that. You have to believe in your brain, and you have to limit the part of the computer and how much that takes over. So those are the two things that I would say on that one.
Great comments. Yeah, I agree with both of you. You know, in emergency medicine, we practice evidence-based care, but it's not cookie cutter. And guidelines are guidelines for a reason. They're meant to be applied at the population level, but we have to trust our guts, and that's what training is all about. I will ask if any of the audience members do have a question, just indicate by raising your hand, but I'll go ahead and ask another question to both of you. I'm curious, obviously, both of you are champions and advocates of implementing and researching new technology in emergency medicine care. But there's a lot of systemic inertia that exists throughout medicine, and especially in our specialty. I'm curious, how receptive have your colleagues been to adopting this new technology, or even having a conversation about thinking about adopting the technology? What are some of the biggest barriers to the adoption? And how do you, I guess, not combat, but massage the idea that new technology can actually be quite helpful in our department and in our specialty?
I think the easiest way to break down barriers is to tie it to physician compensation. So you can be very resistant to AI assisted technology. And if you feel like you are missing out on RVU compensation because you didn't put in that you discuss smoking cessation because you forgot that was part of a billing code somewhere, and AI never forgets that, but listens to you give that discussion, people become much more interested in adopting. I will say, I hope I'm not offending anybody if I say, I think the biggest barrier to adopting AI technologies is likely, or I guess the biggest risk factor associated with not adopting is age. And so as these technologies come on board, I actually think there is a useful component of some of our older physicians putting on the brakes and making us take an extra second to review it. I think as that segment of our specialty goes on to retirement, or like we talked about in the case, or whatever it is that they end up doing, we will lose some of those breaks actually, and we will lose some of that caution.
Yeah, I think that I'm very lucky to work at, a big academic center, and I think and with faculty that are informatics boarded, I think those people tend to be the fast adopters. I think, admittedly, again, the flip side of working at like a big state academic institution is like there can be a lot of inertia with getting certain things adopted. And so, like, we still don't have a bridge available in our ED, which is something, and I wasn't even able to pilot it. And so that's something that's frustrating. Hey, you have somebody who would like be happy to give you sorts of feedback, happy like to test it in this environment, and essentially was told that, well, a bridge isn't ready for the emergency department. And I don't know how true that is or not. I mean, they were doing like vendor selection and they really focused on outpatient settings initially, but that's just kind of an example of there's pros and cons. If I were just at a small democratic group, like how would things would probably be a little bit different. I think, to Dr. Rowe's point about this agreed with kind of the usage of technology amongst different generations of physicians. I think something that I'm seeing now is almost a little bit of an over reliance sometimes on like generative AI. And so the other day I was working and there was an off-service intern who was just taking all of things, like had written down some things and they're just like copy and pasting things into ChatGPT. Just like, please generate a differential diagnosis for chest pain for this 48-year-old male. And I had someone be like, hey, it's like, yes, you can use this to augment, but like also please make sure that you're not just totally doing this verbatim because it could write some really crazy stuff that you don't necessarily want it to say. And so, yeah, it's this very delicate balance.
Yeah, I think that's really interesting on the comments from both of you talking about maybe what you could call both ends or yeah, both ends of the experience spectrum. The end that is far more experienced, maybe being quite hesitant to adopt these new technologies because they have the experience, and the folks on the newer end of experience with very little experience over relying on it and maybe not thinking, is this actually correct? And is this correct in this context? So that will be an interesting challenge moving forward as trainees continue to engage with these technologies as they become more prevalent in the emergency department. I'm curious if either of you could comment on if you had this scenario where you could design an ideal tool for the emergency department, maybe something we haven't talked about today. What would it do differently from what's currently available? Or alternatively, are you working on anything that you're really excited about that you are able and willing to share with the group?
I can go first, I guess, then. So I think predictive models are going to become super important as we talk about healthcare, everything. The problem with predictive models is that they only use information that we have available to it. And so, what do you have on every single chart that you can then compare and differentiate between folks? So, I predominantly look at age and risk factors associated with age. And I have a hypothesis or theory after working through this so much that there's actually a physical activity or basically the opposite of frailty that much better predicts outcomes related to trauma, even independent of age. But because that physical activity is usually so tied with age, we use age as the proxy. But as our population ages and our younger population gets sicker, those will start to decouple. And we have no way of measuring that. And so, one of the things that I think will be the most important as we move forward, for those of us who worked during COVID, everyone remembers the sepsis alert that then started to activate for every single COVID patient that came into the emergency department. And they actually had to turn off that function because COVID wasn't a thing before. And so all of a sudden, sepsis alerts was on every single patient that came in, and it was just the most obnoxious thing in the world. Much like getting new data in will completely change your model, I think we now have to be smarter than the predictive model generation. My dog is coming into the room. And say, what information do we now need to gather on a larger scale, whether it's population based, whether it's information that we can generate from groups of individuals that will be better at predicting. We have to be smarter. We have to be able to say, what does my model need in order to predict this that it currently doesn't have? Because we can all say age is the predictor of everything, but there has to be more specific information that will help us look differently at 65-year-olds, for example. And I think if we remember to be smarter than the models, we will be able to get it, but give it better information and get more of what we want out of it. So that we're not just taking everybody who's 76 years old and putting them in the hospital because they're probably going to come into the hospital anyway.
Am really curious. I want there to be smarter AI chart summary. I think something that I think it probably infuriates all physicians, but especially in the emergency department, is like the amount of note bloat that we deal with and just the amount of unimportant things that are available in the medical record. Like the medical record is great because a patient just says it's in my chart and I can go and I can then look that up. But at the flip side, like I don't need to know about if a patient's there for chest pain, I don't need to know about their knee replacement in 1995 that is listed in Epic as right next to their STEMI 2 years ago. And I think that it has a way of doing that. It can be really hard to kind of parse out important information. And so I've kind of described as like my white whale is like smart chart summary, which I think something AI should be able to do. I think the difficult issue is probably context dependent, and it's also going to be just you're going to have to do a lot of training on what things aren't important based on the chief complaint and things along those lines. I think I saw that again in this Epic kind of keynote. Is that something that's coming, or at least they've been working on it? I think they potentially say that, and who knows when it's actually going to be out. I also know that there are a lot of third-party companies working on that. I haven't seen anything that is kind of feasible or anything that's impressed me, but that I think would be from the ED standpoint, just thinking about like how we access information and wanting to access important information quickly, I think that would be pretty amazing.
Fernanda just commented, we have several predictive models implemented in Epic, but the challenge is how to study its effectiveness and how they are used. Example, we have an admission prediction, a palliative care needs alert, and a CHF prediction based on the EKG. How do you study these interventions to demonstrate if they do or do not work? Great question. Thank you, Fernanda.
Some of our large data sets are going to give us more information on that, right? So Kronos is now available to anybody who works with Epic and wants to sign up. And you can do a lot of investigations through these incredibly large data sets. So previously, and I consider myself one of the older folks here, the only large data set you could get in trauma nowadays, or back in the day, was the NTDB. And it had very specific information for millions of patients across the United States. I think that will now be available for medical patients, for admitted patients, for discharged patients, and we'll be able to demonstrate if these are reliable. I think that's the way to think about it. That being said, again, there are things that you pick up on individual patients. Like even if you have a predictive model that says this patient is definitely going to palliative care, and there are things, as we talked about with the context presented with our previous patient, that pull you out from believing that's the best thing for this patient. We really need to make sure that we listen to that, and we realize that population risk is different than individual risk for a variety of reasons, and make sure that we are not putting people into boxes based on population risk. This is also something we talk about all the time when we talk about BMI, for example. So if I have somebody who has an overweight BMI who runs half marathons with me, like I'm not concerned about the same risk if they are an overweight individual who's sedentary. And I think those types of, when I talked about what we're putting in these models, those types of information are not currently available and definitely change how you interpret information. So we have to separate out that individual and population risk, even as these get better.
Yeah, it was interesting when I worked on the admission prediction model. I remember at one point, one of the ED docs I was working with is, so this is just a fancy model for that a seasoned ED doc could look at and just be like sick or not sick. And we all kind of laughed about that. We're like, yeah, so maybe we're kind of solving this problem, or we're solving a problem that you can already solve by just having experienced doctors in that role. And I think that for each of those models, to me, is I think you kind of have to get to the so what. And so for us, for my model, is like the so what, we were really interested in like the implementation of it. And does this decrease boarding time, or does this like somehow decrease bounce backs or something else along those lines? I think with COVID kind of putting a wrench into everything, there was the initial goal was basically to be able to develop this model and then to be able to kind of look at some of those like more downstream effects. But I think each model is kind of unique in how you think about what its effects are like and how you're evaluating it.
I'll just piggyback on that real quick. I know we're leaving. We did a predictive model related to geriatric trauma, and we were predicting who was going to go into rehab. So if you could imagine being someone who just crashed their car or fell over or fell on their bike and being told, we know that you are likely to go into rehab in 6 or 7 days. Just think about sort of what that means for that patient and how we start planning for their dispo beforehand and how that changes how they're perceived during their entire admission with the trauma service, if that's where the team has already predicted they're going. So totally hear everything you're saying about these predictive models. It's very fascinating.
Yeah, I think one theme that I'm really pulling out from kind of all of the discussions that we've had today is that these technologies are tools. And these tools are only as good as the components that are used to build them, and only as effective as the person that's actually wielding them, in the sense of how they actually think through the use of the tool. And again, we don't practice cookie cutter medicine. And I think all of us here would agree that the goal of these tools is not to create a rubber stamp on all of our charts or all of our clinical decisions. But I'm really hopeful, especially after hearing about everything that you all are working on in your experiences, that as we go into this new future with all these different options for improvements in our departments and technologies we can use to help patients, that we'll be able to do that as a specialty in a safe and effective way. We are unfortunately out of time, but I really appreciate you both presenting to us today. Thank you so much for sharing your experiences. And thank you so much to Juana and the rest of the SAEM team for helping to organize this and recording it and making it available to everyone at SAEM.
Thank you, John.
Thank you, everyone.
Have a great day, everyone.